So now about dyslipidemia wrap-up in 2020. And I think dyslipidemia and atherosclerosis has been gone through a lot of development in the last few years. I think all of you know the main central illustrative slides of dyslipidemia in the last 2 years, the European guidelines of dyslipidemia. And we now have a new target and new goals of therapy for LDL, which is a very tough goal of therapy, especially in those at very high risk, for whom we have to go to 50 milligram or below 55 milligram per deciliter. So determining the risk of the patient is very important to see the goal. Despite all of this, we still have residual risk. And as you see, the major statin clinical trials showed that despite the reduction of event rate in those receiving statin and those receiving placebo, however, we still have those residual risk around for example, if you look at the 4S study, we decreased the risk from 28% to 19%. So still you have 19% despite statin therapy, despite high intensity statin therapy. We know that this residual risk may be due to inflammation, may be due to thrombosis, but the main issue is lipid and achievement of lipid goal. One of the most important point that we have looked at is what we call the earlier is the better. We know that all of us are born with liability to atherosclerosis if we are genetically determined. For example, those with homozygous familial hypercholesterolemia may have atherosclerosis at very early of age, 12, maybe less. Those with heterozygous familial hypercholesterolemia may have atherosclerosis at the age of 30. Normally, you should have atherosclerotic heart disease according to the risk factor, maybe not less than the age of 60 years. So if we can detect those liable to atherosclerosis at earlier stage of life and start primary prevention for them, at least with lifestyle modification and also with the statin for those who deserve therapy. So this is very important, detecting those liable atherosclerosis at earlier stage of life. One of the important development in the last few years is the increasing role of the non-statin lipid-lowering therapy in the management of patients with atherosclerosis, whether in primary prevention or in secondary prevention. Many of us know about the improved trials and the ezetimibe addition to statin therapy in patient post-acute coronary syndrome, and you know, of course, about the major development, which is monoclonal antibody PCSK9 inhibitors, 4-year trials and ODIS trials. And actually, PCSK9 inhibitors is an important part of therapy nowadays, especially if you cannot reach the goal with high-intensity statin therapy and even with combination therapy. We have a lot of PCSK9 outcome trials in the last few years. We have the 4-year trials, more than 22,000 patients. We have the SPIRE 1, SPIRE 2. We have the Odyssey, about 18,000 patients. And we have now evidence that adding this non-statin therapy to the high-intensity statin therapy, those who are not achieving the goal can help you achieving the goal in the majority of your patients. Another important point, if we look at the guidelines for PCSK9 inhibitors, the cost effectiveness is still a very important issue. However, if we ignore the cost of the drug, I think any person indicated for statin and not reaching the goal should receive PCSK9 inhibitors. However, because of the cost, we restrict that to those at very high risk, example, those as repeated acute coronary syndrome, those with LDL cholesterol are still above 70 or 100 despite statin therapy, those with heterozygous familial hypercholesterolemia and atherosclerotic cardiovascular disease not reaching the goal with usual statin therapy. We have also many other drugs rather than statin therapy. One of them is pumpidoic acids, and actually pumpidoic acid act on an earlier step in the biosynthesis pathways of cholesterol in our body. A step before that worked by the coenzyme A reductase inhibitor statin therapy. It is selective acting on the liver. It is could be used in those with statin intolerance or not achieving the goal with statin therapy. Another important development is the importance of triglycerides and the treatment of hypertriglyceridemia, because for many years we know that triglyceride is very important risk factors, but we failed to prove that treating hypertriglyceridemia can lead to cardiovascular risk reduction, except after the reduced trial and the use of omega-3 fatty acids, and now it is in the guidelines class 2A and 2B. I think then the most important new development in the last months of the years, and they will change the future of treatment of dyslipidemia, is the use of RNA therapies or gene silencing using microRNA or inhibitory RNA to prevent the formation of the protein from the start. And we have inclisiran, we have some clinical data about its efficacy and its safety on the patients. And I think the small interfering double-strand RNA is the base of the future therapy in many of the field of atherosclerosis. And this is the lipoprotein target for the future, which can be genetically validated target: LDL cholesterol, ApoB, triglyceride ApoC3, lipoprotein little a, and also NGLP TL3. So I think the future will show a great change in the management of dyslipidemia, especially regarding genetic scoring, early detection of those liable for atherosclerosis, and the use of these modern new therapeutic modalities in the treatment of dyslipidemia. Thank you very much for your attention.